Good evening. Your Excellency, Dr. Abyad, Minister of Health, dear faculty, staff, colleagues, and esteemed guests. First and foremost, we would like to thank everyone in this hall and attendees joining us over Zoom for allocating time in their busy schedule to attend the dissemination session of the Lebanese vitamin D guidelines. This achievement is the fruit of a 4-year hard work led by the Calcium Metabolism and Osteoporosis Program at AUB under the leadership of Dr. Ghada Al-Hashflayhan, in collaboration with the Great Center at AUB led by Dr. Eli Aql. At this point, we would like to thank every person who contributed to the success of this initiative, starting by the Systematic Review and Meta-Analysis team for their expertise in data collection and compilation, the faculty members of the Guidelines Executive Committee for their relentless efforts to develop these guidelines, the national and international panel members for their insight, time, and input, and the coordination team for the support throughout the process. We are honored to start our session with a pre-recorded address from President Khouri, who is currently in New York City at a meeting for the Board of Trustees. Dr. Khouri is the 16th president of the American University of Beirut. He is former Executive Associate Dean of Research and former chair of the Department of Hematology and Medical Oncology at Emory University School of Medicine, and served as Deputy Director for the Winship Cancer Institute at Emory University. Dr. Khouri was also the Roberto Guazueta Distinguished Chair for Cancer Research. He is a leading clinical and translational investigator and a world authority in lung and aerodigestive medical oncology. Dr. Khouri's leadership throughout his tenure as president, and importantly, despite the challenges incurred by the 2019 collapse, has been instrumental in ensuring that AUB's mission to provide excellence in education, to participate in the advancement of knowledge through research, and to serve the people of the Middle East and beyond remains unscathed.
Esteemed guests, colleagues, friends, greetings from New York City, and thank you for being at this great meeting today and allowing me to join you in this celebration of collaboration, science, and progress, even if remotely. The Lebanese guidelines for vitamin D supplementation in adults are the fruits of an unprecedented national initiative, one that started 3 years ago, and that was only possible through a remarkable, wide-ranging collaborative effort between the Calcium Metabolism and Osteoporosis Program, CAMOP, and the Great Center at the American University of Beirut. These national guidelines fill a major knowledge gap, as well as providing an important care gap and bridging that gap. They are based on rigorous international standards. They provide valuable evidence and systematically derived recommendations that will shape public health policy regarding vitamin D supplementation in Lebanon for years to come. They also provide a useful paradigm for the formulation of regional vitamin D guidelines. The vitamin D field has witnessed a great deal of progress and many high-tier publications over the last 2 to 3 decades. Much of this work has been led by our own Dr. Ghada Al-Hashflayhan. However, these publications presented conflicting recommendations from several organizations worldwide regarding vitamin D supplementation. Furthermore, many guidelines were derived through expert opinion rather than careful examination of the evidence available at the time they were published. The Endocrine Society and the National Academy of Sciences simultaneously published their guidelines in 2011, but again came out with conflicting recommendations regarding dosing and desirable levels, adding to the prevalent confusion and controversy, both of which still linger today. These Lebanese guidelines for vitamin D supplementation being disseminated today were developed anew and anchored in the latest evidence available today, including 2 specifically designed systematic reviews and an umbrella review of systematic reviews and meta-analyses, all of which informed the guidelines panelists. This draws on the exceptional work of Dr. Lil Aql, Dr. Mada Hashflaihan, and others in developing rigorous guidelines. These guidelines are based on the rigorous grade technology and address 3 pre-specified important clinical questions regarding the role of vitamin D supplementation to prevent fractures. These questions are: should vitamin D supplementation, with or without calcium, versus no supplementation, be used in adults in Lebanon? Should testing for vitamin D deficiency versus no testing be implemented across all adults in Lebanon? And finally, what is the optimal vitamin D supplementation dose, if recommended, to specific adult subpopulations? I would like to close by thanking all those who contributed to the success of this important national effort, including the multidisciplinary panel of national and international experts, the Guidelines Writing Committee, and the Guidelines Executive Committee that spearheaded the work. Thank you all, and have a great conference. Esteemed guests, colleagues.
Dr. Raymond Sawaya, also on travel in New York City for the BOT meeting, will be addressing us virtually on this occasion. Dr. Sawaya has been appointed as Raja Al-Khouri Dean of the Faculty of Medicine and Vice President for Medical Affairs at AUB, after being a professor and the founding chairman of the Department of Neurosurgery at the University of Texas MD Anderson Cancer Center. He was also the director of the Brain Tumor Center at MD Anderson Cancer Center and chairman of the Department of Neurosurgery at Baylor College of Medicine. Dr. Sawaya has received various awards and has also served on numerous medical journals and is frequently requested as a national and international lecturer. He is a noted leader in the field of neurosurgery with particular expertise in primary and metastatic brain tumors. He is renowned for his great strides in enhancing the accessibility and safety of brain tumor surgery.
Dear colleagues, it gives me great pleasure to recognize and to commend you on the launching of the Lebanese vitamin D guidelines. Osteoporosis is a serious health problem that affects women as well as men. It is frequently undetected and under-recognized and can result in significant bodily injuries. A key set of questions raised by this committee was aimed at defining the role of vitamin D supplementation in preventing fractures. To this end, a multidisciplinary panel of national and international experts was assembled, and rigorous methodology were employed to produce the scientific evidence required for such a national effort. I'm particularly proud of the role that our Faculty of Medicine at AUB played in advancing the committee's goals, including our calcium, metabolism, and osteoporosis program, led by Dr. Rad Al-Hashflaihan, along with Dr. Marlene Chaktoura and Asma Arabi, as well as the director of the GRADE Center at AUB, Dr. Eli Aql, who was also the co-chair of the guideline committee. However, in the end, the validity of such guideline rests on a truly multidisciplinary participation that gives the conclusion of these recommendations the required authority. I therefore extend my appreciation to each and every one of you who participated in this effort, hoping that your diligent work will be translated into a healthier Lebanese population and beyond. Thank you.
His Excellency Dr. Firas Abyad, Minister of Public Health in Lebanon, graduated from the Faculty of Medicine at AUB with subspecialized training in bariatric surgeries from US and UK universities. Previous to his appointment as minister, Dr. Abyad worked as gastrointestinal surgeon at AUBMC since 2010 and served as the chairman of the board of directors at Rafiq Hariri University Hospital since 2015. During his tenure at Rafiq Hariri University Hospital, he led the efforts to turn around the hospital to a leading tertiary hospital that spearheaded the COVID response in Lebanon. In 2021, he earned the recognition of the 2020 Man of the Year by the Arab Hospitals Federation for his role in RHUH, especially during the COVID-19 pandemic. Dr. Abyad has headed the Ministry of Public Health at particularly one of the most severe and complex crises in its recent history, caused by the interplay of political turbulences, socioeconomic meltdown, and the lingering COVID-19 pandemic. Despite these challenges, Dr. Abyad has been focusing on strengthening primary healthcare services, system digitalization, and medication use rationalization. Dr. Abyad, the floor is yours.
Dear colleagues, so it gives me really great pleasure to participate alongside all of you in the launch of the Lebanese vitamin D guidelines that's organized by the Calcium Metabolism and Osteoporosis Program at AUBMC. And really, I would like to talk about three particular topics. The first one is that during this period of low resource environment in Lebanon, the utilization of resources becomes extremely important, and decisions pertaining to the utilization of resources have to be based on scientific data. For policymakers and decision makers, I think the presence of this guidelines and the study of local data that can lead to these guidelines becomes particularly important as we try to see what would be the best way to allocate resources to ensure that the right treatment or supplement reaches the right patients and not to lose any resources that are available. The second issue that is also important for us at the Ministry of Public Health, as we are trying in our national health strategy to move away from expensive tertiary care into a more sustainable emphasis on primary care, I think the issue of nutritional deficiencies become extremely important. And this is why we have launched at the Ministry of Public Health our Nutrition National Plan to look at that. And obviously, we all know that vitamin D deficiency is very important and can play an important role in the occurrence of a lot of diseases, including expensive fractures that are then a big burden on our healthcare system to treat, especially in these times of want. And therefore, I think that to address this issue for us fits within our strategy of prevention that we are following at the Ministry of Public Health. The third issue, I think, for me, is the pride that these national guidelines have been launched at my alma mater, at the American University of Beirut, and at a center of excellence such as the Calcium Metabolism and Osteoporosis Center, and led by Dr. Ghada Hashif Layhan, and also the research led by Dr. Eli Al and their colleagues. I think that during these times of darkness that are passing over our country, these centers of excellence and the role that is played by the academic medical centers become extremely important as beacons of light during these times of darkness. I think that once, if you look at history, Lebanon has been lifted in the past by these universities that have spread knowledge in our country and has helped Lebanon to become at the forefront of this region. And I do hope that also, again, these academic centers will lead the rejuvenation of our country and hopefully lead us into a brighter future. Thank you.
Thank you, Dr. Abyad. Dr. Francesco Branca, the Director of Nutrition for Health and Development at the World Health Organization, was supposed to join us over Zoom, but he was not able to do so for unexpected reasons. So we will be moving to Dr. Rana Hajji, the Director of Program Management at the World Health Organization Eastern Mediterranean Regional Office. She is a senior public health leader with 30 years of experience in public health, health policy and diplomacy, and health management, especially in the Middle East region. Dr. Hajji worked with the United States Centers for Disease Prevention and Control for 23 years prior to joining WHO EMRO. Dr. Hajji, the floor is yours.
Thank you, Stephanie. Can you hear me?
Yes, we can hear you.
Okay, great. Okay, thank you very much, and good afternoon, colleagues, Your Excellency. Thank you very much for actually inviting us to be part of this very important lunch. I would very much like to congratulate Dr. Ghada Al-Hajj Flayhan as leading the development of the guidelines, but also as the team lead of one of our WHO collaborating centers. Dr. Ghada has the WHO Center for Metabolic Bone Disorders, and it's always for us a big real achievement for us to see our collaborating centers producing and contributing to the generation of such important evidence-based guidelines. Maybe to comment briefly on some of the issues that were not mentioned yet, developing evidence-based guidelines for clinical management is becoming increasingly very important, as His Excellency just pointed out, to develop better and more cost-effective primary healthcare. And recently, WHO established actually an evidence unit just focused specifically on building capacity for evidence-based guidance in the region. But also, more importantly, the need for us to address the issues that are relevant to nutrition overall. And in 2019, all of the member states in the Eastern Mediterranean region endorsed the overall strategy on nutrition 2020-2030. So there's already a commitment by our countries to a vision of strengthened action on nutrition to achieve food security in general and all forms of malnutrition, and improve nutrition throughout the life course by 2020. So I think the addition of these guidelines for Lebanon at this point for vitamin D guidelines is a very important step.
Dr. Hajji, can you hear us?
We apologize. It seems Dr. Hajji is having some technical difficulties. She will be rejoining in a few minutes.
Dr. Hajji, I don't know if you can hear us. It seems that we may have lost you due to connectivity problems. I think we will wait a minute, and if she's not on, we'll just proceed. Just want to take the opportunity to thank His Excellency Minister Abyad, our dear faculty and colleagues, our panelists, our students, and our working teams for being in person with us. We have many people, as you can see on the Zoom. This is the price we pay with hybrid meetings, but we're excited and we're thrilled to have you with us. We're just going to proceed to respect your presence and the time with the program.
Dr. Hajji? Dr.
I'm
Hajji,
sorry. Yeah, I'm sorry, Stephanie. I'm actually calling. It's not even in Cairo. I'm calling from a meeting in Europe, and the internet connection has been very unstable. Anyway, I apologize about the internet issues. Just wanted really to thank everybody and highlight the role again of major academic institutions in the region in terms of supporting the overall regional strategies for nutrition, focusing specifically also on especially issues of importance to public health, such as vitamin D deficiencies, and also overall many other conditions that need more of the evidence-based guidance. So thank you to all who contributed to this important guidelines, much appreciated, and look forward to your help with developing the regional guidelines. Thank you very much. Over to you.
Thank you, Dr. Hajji. Dr. Ghada Al-Hashfleihan, Professor of Medicine and Physician Scientist at the American University of Beirut, is founding director of the Calcium Metabolism and Osteoporosis Program, WHO Collaborating Center for Metabolic Bone Disorders, and of the Scholars in Health Research Program at AUB. She leads a team that conducts clinical trials, systematic reviews and meta-analysis, and translates finding into prevention and treatment strategies for osteoporosis and metabolic bone disorders. She closely collaborates with the Ministry of Health officials and international experts to generate evidence-based national and international clinical care pathways. Dr. Hashfleihan is the chair of the Lebanese Vitamin D Guidelines Executive Committee. She will provide a brief introduction for the 2022 Lebanese Vitamin D Guidelines. Dr. Hashfleihan, the floor is yours.
Thank you very much, Stephanie. I'm very, very excited to be here, as I said, and it's wonderful to be able to see the fruits of a long-term collaboration finally come through despite all the challenges we've been facing over the last several years. And there is nothing more rewarding than to do so as a member of the WHO Collaborating Center, an essential one that has advanced the research agenda on nutritional factors in Lebanon and the region. And we hope these would be a useful paradigm for regional adaptation. I'm going to be very brief to set the stage for Dr. Ael and Dr. Shahtoura to present the meat of the work and then conclude with the recommendations. I'll start with a brief overview of vitamin D deficiency worldwide and in the Middle East. Just give you a sense of the multitude of vitamin D guidelines worldwide and in the region, with contradicting results regarding supplementation, but more consistent recommendations for testing. The Lebanese guidelines for osteoporosis first update in 2013 mentioned vitamin D supplementation. It included guidance on lifestyle factors. It specified calcium and vitamin D dosing guidance and provided guidance on vitamin D testing. And finally, here we are today, 2022, with this amazing initiative that we're excited to share with you. So as you can tell, vitamin D deficiency or low levels below 20 nanogram per ml, assuming a perfect assay and standardization, is quite common, not only in Europe, where 50% of the population will be below 20, but in Asia and also in the Middle East. Children are in blue, adults or elderly are in orange and gray, and you can see that the mean level is in the mid-teens, which is below the desirable level that has been so often quoted by multiple organizations. This is wonderful work led by Dr. Shahtoura and our team a few years back, looking at vitamin D in the Middle East and North Africa specifically. What I'm showing in this bar graph is the weighted mean of vitamin D with the pooled standard deviation in adults in purple, children in light gray, and pregnant women in dark gray. And the numbers per age group varied between 2,000 and 6,000. These are not small studies. And we can see Bahrain first, Iran, KSA, and Lebanon. Starting with Lebanon, the mean level in adults is just around 20, meaning 50% of the population would be below that, and children just at the 20 cutoff. This situation is even much worse in countries in the Gulf, such as KSA, where the mean level is in the 13, 14 range. Same trend in Bahrain for adults. Iran may do a little bit better. Again, these assays are not harmonized and standardized against an international standard. Why are we so interested in vitamin D? Well, to make a long story short, today we're talking about musculoskeletal health, specifically fractures, and this graphs illustrate the relative risk of hip fracture plotted against vitamin D doses going from 340 IU to 760 IU. No risk is 1, risk reduction is below the 1 line, and increased risk is above. And you can see with more replete supplementation dosing, the risk of fracture decreases and the levels reached are around 20 to 30 nanogram per ml. So where does this leave us? They are numerous. This is just a taste of what's out there. There are probably hundreds of vitamin D guidelines that have been published over the last 2 decades with very conflicting results. The one that has really kind of been highlighted over and over again are the one by the Institute of Medicine that recommended for adults 19 to 70 years, 600 IU per day would be sufficient, and for above age 70, 800 IU would be sufficient. The Endocrine Society had a different perspective. It focused on higher risk individuals and recommended between 1,500 and 2,000, and for the elderly, same dosing. Suffice it to say that our group has scrutinized the evidence examined by these 2 organizations, and the evidence for bone density and fracture was quite humbling. Vitamin D guidelines in the MENA were able to identify 2 from the Kingdom of Saudi Arabia and 1 from the UAE, recommending doses anywhere from 400 to 800 in KSA. Same country from another author, higher doses 1,000 to 2,000 in pregnant women and postmenopausal women, and the UAE following a similar trend for higher doses. As I said before, none of these guidelines was based on a rigorous systematic review on vitamin D related outcome, dose response worldwide or in the MENA. Most were based on expert opinion and review of the evidence from Western country regarding target doses and desirable levels. The story is a bit more consistent for vitamin D testing. The American Society of Clinical Pathology, the American Academy of Family Physicians, the Endocrine Society, and the American Association of Clinical Endocrinologists all recommend against screening and focusing screening in high-risk individual in the latter 2 in organization. And high-risk individuals, for example, are those with rickets, osteoporosis, CKD, liver disease, malabsorption, hyperparathyroidism, medications that cause abnormalities in vitamin D metabolism, and some granuloma-forming diseases. In 2013 was our first update for the Lebanese osteoporosis guidelines that was based on the FRAX calculator that our collaborating center has launched in 2009. Although these guidelines have focused on pharmacologic therapy with clinical care pathways that are posted on our website, we included guidance for calcium and vitamin D. We said that serum vitamin D should not be measured in private routine practice, and it should be measured in following circumstances: high-risk individuals, osteoporosis on drug therapy with fractures, conditions known to affect vitamin D metabolism or action, or people who are high risk and on high doses. These were the Lebanese osteoporosis practice guidelines. They were endorsed not only by the Ministry of Health, but multiple societies, including endocrinology, OBGYN, rheumatology, radiology, orthopedics, and family medicine. And the doses recommended for adults less than 50 was 600 to 1,000, and high-risk individuals and older individuals between 1,000 and 2,000. This was based on expert opinion. So here we are today, and I'd like to acknowledge first our guideline teams for systematic reviews and meta-analyses, Dr. Marlene Shahtoura and Asma Arabi, and of course the great center, Dr. Ael. The executive committee are Dr. Ael, myself, Dr. Shahtoura, and Dr. Arabi. The guidelines coordination team was Dr. Stephanie Antoun and Mrs. Joanne Habsa from the Great Center. These are the vitamin D evidence provided. This is an umbrella review that we're very proud of, led by Marlene, students from AUBMC, fellows, international experts, Dr. Roger Bouillon, Paul Lips, our own Dr. Elia Ael, as well as Peter Ebling. And that provided the evidence for fracture risk reduction from a very rigorous systematic review meta-analysis by the Cochrane group that Dr. Shahtoura will show you. For the vitamin D response, dose response, this was a pure MENA-led data availability. This is a paper that is ongoing. This was based on the thesis of Dr. Shahtoura a few years back with a very recent update presented at the ASBMR this year, and the paper is in preparation. It's an updated systematic review and meta-analysis of randomized controlled trials in the Middle East and North Africa on vitamin D replacement in adults, and you'll see some of those results. And the last one was getting patients' input, which is a very rare but extremely important parameter to take into account when talking about vitamin D guidelines. We can generate all the guidelines we want. If we do not have the patient's perspective, we will never be able to implement these guidelines. So this was an unprecedented, really Herculean effort by Dr. Malik Naifi and Dr. Hala Ahmadi, our own graduates from AUB, with us, who basically conducted a systematic review on preference, attitudes, and knowledge regarding vitamin D supplementation in the MENA region. And we complemented that with a survey in our own patients in the clinic. So the three questions that are relevant today are, one, should we test Lebanese adults for vitamin D deficiency? Two, should we recommend vitamin D supplementation with or without calcium to Lebanese adults? And three, what is the optimal dose for adults in Lebanon? And we examine these questions separately for community dwelling and for institutionalized individuals. It takes a village to generate such a powerful and really uplifting document with recommendations. And I'd like to acknowledge them one by one. In addition to the teams mentioned from our endocrinology colleagues, Dr. Paula Atalla, rheumatology, Dr. Rafiq Baddoura, endocrinology again, Dr. Maya Baraki, Roger Bouillon as international expert endocrinologist, Dr. Akram Shrey, previous president of the Lebanese Society of Endocrinology, Dr. Imad Kibbe, who is no else than the husband of Dr. Rana Haji, was a team member at AUB and now left us to the region. Dr. Marie-Hélène Ghannaji with us, endocrinology. Dr. George Halabi, endocrinology. Dr. Nadine Hlal, who is a rheumatologist and is a consultant for the Minister of Health. Dr. Paul Lips, endocrinology. Dr. Jada Ace, rheumatology. Dr. Muna Asman, family medicine. Dr. Mehiddin Saoud, OBGYN, and Dr. Imad Osman, rheumatology. And it's really a wonderful panel who has time and time again come through on Zoom and in person to attend our informative session to vet the evidence and vote on the evidence and come out with the recommendations you will see. As per due process, all members have to declare conflict of interest, which was clearly available for anyone to review and will be published with the guidelines, was vetted by myself and by Dr. Aer, but also my own conflict, which is listed there, was vetted by the Endocrine Society Chair of Clinical Practice Guidelines. And now I'd like to lead the floor to my colleague, Dr. Elia. Tfaddali.
Dr. Eli Ael is a tenured professor of medicine at AUB, where he serves as the Associate Dean for Clinical Research, leads the Division of General Internal Medicine and Geriatrics, and directs the AUB Great Center. He is also affiliated with McMaster University in Canada. His research expertise is in systematic reviews, practice guidelines, and conflict of interest. He serves as a guideline methodologist for a number of North American and international professional societies and for the World Health Organization. He published close to 500 peer-reviewed papers and was listed by Thomson Reuters in 2015 as one of the world's most influential scientific minds and as one of the highly cited researchers yearly since 2015. Dr. Ael is the co-chair of the Lebanese Vitamin D Guidelines Executive Committee. He will explain the grade approach used to develop the Lebanese Vitamin D Guidelines methods. Dr. Ael, the floor is yours.
Thank you, Stephanie, and good evening, everyone. Thank you for the kind introduction. It's a real pleasure to be here, and I would like to start by thanking Dr. Ghada Al-Hajj Flayhan for giving us the opportunity to be part of this project. I was just chatting with Dr. Ghada, and she was saying this was a good rodage for us for future projects. So you can guess when Dr. Ghada is saying rodage, we are going full speed, full energy. And this was a really amazing effort. So the grade methodology is the top methodology being used in developing guidelines worldwide. Our center supports the WHO as well as international organization. We also lead methodological work on different types of guidelines, including how to develop rapid guidelines, living guidelines, but also how to adapt guidelines. And we've worked with many ministries in the region on how to adapt guidelines, because adaptation, as you can guess, is much more efficient, takes less effort. But in this case, this is, I would say, the first full guideline we developed de novo in the region. And I can attest it's been one of the best guidelines, thanks to the effort of the team and the quality of the work and of the panel that we had. So a brief review of the methodology. So earlier you looked at the questions that were addressed by the guidelines. And the questions are typically, they reflect the priority questions of the target audience. What is the target audience is interested in answering? Which question? So the recommendation is nothing but the answer to those questions. So what you will see at the end, the recommendations are the answers to the questions we looked at earlier. In terms of the methodology, it's a very intensive methodology. So I can tell you that most organizations spend 2 to 3 years to complete their guidelines project. They spend hundreds of thousands of dollars to develop those projects because of the resources required to go with that. So you see there are different steps. This is one way to illustrate them. One, the scope of the guideline. Two, getting the guideline development group together. We mentioned the PICO question, or the questions in number 3, and then comes the hard work. And this is where really the hard work happened with the team doing the systematic reviews. And what was special about this work is that the systematic reviews not only addressed the questions of effectiveness and safety of the interventions, but also the contextual factors. So His Excellency, Dr. Abiad mentioned earlier the importance of being cost conscious, especially in our case. So that was a particularly important area for the systematic review and looking at what we call the contextual factors. And then comes the later step, grading the evidence. And 6, this is where the panel came together. And I can tell you the panel was very insightful in terms of the input on both the science and the local expertise and the local perspective. So this is how we ended up with these recommendations. So what I'm listing here are the factors that the panel took into account one by one in a very structured way, going through them one by one. We divide them into 2 sets. The first one is about the evidence on health effect. So what would happen if you screen versus not screen in terms of fracture, in terms of adverse events, et cetera, et cetera. So that was the first part, but that was not enough. As I mentioned, the contextual factor were as important. So the panel looked at the resources required if we are going to recommend a certain action. Equity is extremely important. So how would a recommendation affect a vulnerable group? If we go, let's say we recommend vitamin D across the board, is this gonna affect in a negative way a certain subgroup? Same with acceptability and feasibility. So the panel, through a high number of meetings, gathered to discuss in detail all these factors, came up with judgments about each one of those factors. So this is just a random example where, for example, they judge that the desirable effects are small, the undesirable effects varies, and then you could go through the list. But you will see, for example, there was concern about the cost, moderate cost, concern about equity, and you will get to see the details when these guidelines are published about how equity was considered. And eventually the panel voted on the recommendations. So this concludes my talk. I'm going to hand it over to Dr. Shahtoura, but I'm really hopeful that the implementation of those guidelines will achieve the best benefits possible for our population. So hopefully with everyone's help, we'll get to disseminate and implement. Thank you.
Dr. Marlene Shahtoura, Assistant Professor of Medicine at the American University of Beirut, is the Director of the Clinical Research Institute and Assistant Director of the Scholars in Health Research Program at AUB. Her research interest revolves around bone health, osteoporosis, obesity, and the link between them. Dr. Shahtoura is also recipient of several awards from international and national institutions. She is member of the Lebanese Vitamin D Guidelines Executive Committee. She will provide a summary of the evidence generated and used to formulate the Lebanese Vitamin D Guidelines. Dr. Shahtoura, the floor is yours.
Good evening, everyone, and thank you again for joining us tonight. These are the topics that will be covered during this section, and I will start by reviewing the evidence behind screening for vitamin D deficiency. Last year, in 2021, the U.S. Preventive Services Task Force conducted a systematic review to identify the benefits and harms behind screening for vitamin D deficiency. The systematic review identified no studies directly evaluating this topic, and therefore the conclusion was evidence is insufficient to assess the balance of benefits and harms of screening for vitamin D deficiency in community-dwelling adults. And probably this agrees with the guidelines that have recommended against screening for vitamin D deficiency, including the older Lebanese guidelines in 2013. What about vitamin D supplementation and fracture risk reduction? We have conducted an umbrella review of systematic reviews and meta-analyses of randomized controlled trials. This extended from 2010, anchored to the year of publication of the Institute of Medicine guidelines, and extended until 2020. We identified a huge number of potential citations and ended up including 25 systematic reviews and meta-analyses on the topic. So first, let's start by reviewing the effect of vitamin D supplementation alone on fracture risk reduction. We identified 14 meta-analyses comparing the effect of vitamin D supplementation alone to no supplementation on hip fracture. So the right side of the table summarizes the relative risk and 95% confidence interval as reported in the individual meta-analyses. And as you can see, all confidence intervals cross 1, and therefore the meta-analysis suggested no effect of the intervention. And the findings on any fracture were very similar. And accordingly, this was our conclusion. There is no evidence of a significant reduction in hip or any fracture with vitamin D supplementation alone compared to no supplementation. Now, what about vitamin D concomitantly administered with calcium and fracture risk reduction? we identified 12 meta-analyses assessing the risk of hip fracture with calcium and vitamin D supplementation concomitantly compared to no supplementation. So the plot here shows the relative risk and 95% confidence interval as reported in every meta-analysis, and each is represented in a different color. Of course, when the confidence interval crosses 1, this suggests no significant effect of the intervention, while when the effect is toward the left side of the plot, this suggests a significant fracture risk reduction. And as you can see, there were lots of heterogeneity in the results of these meta-analyses, some suggesting a significant risk reduction and others not. We tried to explore the reasons behind this discrepancy, and probably residency was one of the main players. 2 meta-analyses provided subgroup analysis by residency, so institutionalized and community separately. And as you can see, probably the overall fracture risk reduction, and again, here we're talking about hip fracture, was mostly driven by data in institutionalized individuals, while the effect in the community really seems to be very minimal. So we calculated the baseline risk of hip fracture in the Lebanese population. So for the community, this was derived by the hip fracture registry of the Ministry of Health, data for the year 2007. And we estimated the baseline risk of hip fracture in institutionalized individuals based on global data. And we applied the overall risk reduction as reported in one of the meta-analyses published in the Cochrane library. And we ended up calculating the absolute risk reduction and the number needed to treat in both the community and institutionalized individuals. And as you can see, in the community, the risk reduction, so the absolute risk reduction, seems to be small, 50 per 100,000. And the number needed to treat seems to be very high, around 2,000 participants or individuals need to be treated to prevent 1 hip fracture. However, in institutionalized individuals, the effect or the absolute risk reduction is larger, around 350 per 100,000, and a number needed to treat that is smaller compared to the community, around 300 individuals. So the data on any fracture was very similar to the hip fracture data. Again, heterogeneity in the results of meta-analyses. And it seems, again, that the overall effect is driven by the data in institutionalized individuals, while the effect in the community seems to be very minimal. What about the dose of vitamin D and fracture risk reduction? In the community, we identified 2 systematic reviews and meta-analyses, each including 11 to 12 randomized controlled trials. The first one showed that a dose of vitamin D 700 to 800 IU per day reduces hip fracture. And the other one showed that probably a little bit of a higher dose, 800 to 2000 IU per day, is associated with a significant risk reduction in hip fracture. Data in institutionalized individuals is really very limited. We identified only 2 trials from France, published by the same group of investigators, enrolling older adults, mean age 84 years, with lowish vitamin D level, a baseline of 8 to 16 nanogram per ml. And the intervention consisted of 800 IU vitamin D in addition to calcium 1200 milligrams daily. And the 2 trials showed significant reduction in hip fractures, and one of them for non-vertebral fractures. We don't have data on fractures derived from the Middle East and North Africa region. However, we have showed in our meta-analysis that a dose of 800 to 2000 IU per day is able to allow for almost 2/3 of the population to get to the desirable level of 20 nanogram per ml as determined by the Institute of Medicine. Finally, what about adverse events? Again, the data from the MENA region is very scarce. We based our summary on the mega trials of vitamin D and systematic reviews of global randomized controlled trials. So this table summarizes adverse events on vitamin D mega trials that have assessed hypercalcemia, kidney stones, kidney failure, and constipation. And there was a signal for a small increased relative risk in kidney stones in the WHI trial. Adverse events in systematic reviews, here again summarized: hypercalcemia, kidney complications, and gastrointestinal side effects. Again, a small signal for an increased risk of kidney stones and potentially some side effects in the gastrointestinal tract to a lower extent. So in summary, vitamin D alone does not reduce fracture risk compared to no supplementation. Vitamin D and calcium supplementation reduces fracture risk compared to no supplementation. In institutionalized Lebanese adults, so taking into consideration our baseline risk, we need to treat around 300 individuals to reduce one hip fracture, while in the community, the effect is really minimal. The number needed to treat is high, around 2,000 individuals need to be treated to reduce one hip fracture. The vitamin D dose associated with a fracture risk reduction is 800 to 2,000 IU based on global data. And finally, in terms of adverse events, there was a small signal for an increased risk of kidney stones. So thank you, and we'll move on with the recommendations.
Dr. Ghada.
So thank you very much for this data. And now going back to our question, should we screen the population or should we test high-risk Lebanese patients for vitamin D deficiency? Should we recommend vitamin D supplementation with or without calcium to Lebanese adults? What is the optimal dose? And each of these questions would be addressing community dwelling and institutionalized. The recommendations I'm going to be showing you are the recommendations as reached by the expert guideline panels for each question, taking into account the 9 domains that Dr. Ael showed us from risk, harms, and contextual factors. So the panel suggests, not recommends, suggests no screening for vitamin D deficiency, over-screening in Lebanese adult population. This recommendation applies both to community dwelling and institutionalized individuals. It's considered conditional. It's not a strong recommendation with very low certainty evidence. And there was a subgroup which may benefit from screening and testing, and these are individuals at high risk of low vitamin D levels, obesity, bariatric surgery, malabsorption, malnutrition, concealed lifestyle, dark pigmentation, pollution, lactose intolerance, sprue, biliary disease, and the oldest old. B, individuals with osteoporosis, taking into account our review in JBMR showing that all randomized controlled trials with all drugs starting with bisphosphonate, denosumab, teriparatide, romosozumab have been done in the context of with calcium and vitamin D. So the efficacy is in the presence of these 2 nutrients, and individuals on drugs that affect vitamin D levels are considered high risk. So no screening, conditional recommendation, low certainty evidence. What about supplementations? The panel suggests no supplementation with calcium and vitamin D over supplementation in community dwelling Lebanese adults. The remarks, there are subgroups that are likely to benefit from supplementation and the same high-risk groups as listed before. And because of the adverse events Dr. Shahtoura has shown us, the physician treating should consider the caution about potential side effects, especially for those with baseline risk of kidney stones, those with ongoing GI problems. Subjects with low calcium intake should be counseled about increasing calcium intake, favoring diet over supplements because of the studies that showed that kidney stone risk increases with calcium tablets, but does not with dietary calcium sources. So no supplementation with calcium vitamin D in community dwelling individuals, except high-risk populations. Conversely, what about institutionalized? And in light of the data Dr. Shahtoura showed you regarding number needed to treat, efficacy on hip fracture reduction, which as His Excellency said, is a very high, costly disease. 50% of patients with hip fracture lose functional independence. 20% of patients with hip fracture die within a year, up to 30% within 5 years. It's a morbid disease. So the panel suggests supplementation with calcium and vitamin D in institutionalized Lebanese adults. And of course, there are subgroups more likely to benefit. Those at high risk for low vitamin D, Dr. Shahtoura showed you the Chapuis study, where these institutionalized individuals had vitamin D levels ambient of 8 to 16 nanogram per ml. What we didn't show you is their PTH was high, and with the supplementation used by the investigator, the vitamin D level came up, the PTH level came down in conjunction with a 40% reduction in hip fracture. So there are some subgroups more likely to benefit. Of course, those at high risk for low vitamin D, those with osteoporosis, and those on drugs that affect vitamin D metabolism. What is the optimal vitamin D dose if recommended to specific adult subpopulation? We're going to be talking about both community and institutionalized individual. In institutionalized and community Lebanese adults for whom there is a decision to supplement with calcium and vitamin D, underscore high-risk population, the panel suggests supplementation with a daily equivalent of 600 to 2,000 IU along with calcium, not higher doses. There are subgroups who are most likely to benefit, and they're the same as the ones I've already mentioned before. I hope that we've provided you with some meat to reflect. We've shown you the recommendations. I want to share with you, as our panel has put together, Dr. Arabi is going to be talking to us about what our plans are after having completed this substantial amount of work. Dr. Antoine.
Thank you, Dr. Hashflehan. Dr. Asma Arabi is Associate Professor of Medicine, Assistant Director of the Calcium Metabolism and Osteoporosis Program at AUB. Her research interests revolve around endocrinology in general, with special focus on bone densitometry, osteoporosis, metabolic bone diseases, and vitamin D. She serves on several national and international executive committees and task forces. She is member of the Lebanese Vitamin D Guidelines Executive Committee. Dr. Arabi will provide the guidelines dissemination plan. Dr. Arabi, the floor is yours.
Thank you. Good evening, everybody. Thank you for being there, and thank you for staying late. I promise I will be very brief. So the purpose of our guidelines is to enhance evidence-based quality of care for patients in Lebanon and in the region. And for this purpose to be achieved, these guidelines should be disseminated and endorsed. For the dissemination, of course, it started already today with your valuable presence, but this is just the start. We want to disseminate these guidelines to the whole scientific community in Lebanon, and we want to also disseminate these guidelines to the public, to our community who would benefit the most from these guidelines. So the scientific community includes the Ministry of Public Health and the Lebanese medical scientific societies, whom members usually either request vitamin D testing or prescribe vitamin D to their supplements to their patients. And these include the Lebanese Society of Internal Medicine, the Lebanese Society of Family Medicine, the Lebanese Society of Endocrinology, Diabetes and Lipids, the Lebanese Society of Rheumatology, the Lebanese Society of Orthopedics, and the Lebanese Society of Obstetrics and Gynecology. For the endorsement, what we will do, we'll share the document with the Ministry of Public Health and request endorsement through the Lebanese Task Force for Osteoporosis and Metabolic Disorders. And for endorsement by the societies, the medical societies, we will share the document with the executive committees of these societies and request endorsement, but we will also collaborate with these societies in order to disseminate the guidelines through presentation of the evidence and the recommendations during their annual meeting, but also through presentation via case-based approach during their monthly meetings or other activities that may be organized by these societies. We also, of course, intend to submit these guidelines for publication in the Lebanese Medical Journal and in other journals, including international peer-reviewed journals. Now, for the public, we need to engage the public. We need to teach them about the guidelines. Of course, we will present them to the public. We'll arrange to present them during awareness days in a simplified manner, of course, that is tailored to the understanding of the public. We will give also lectures in collaboration with NGOs. We will give them to their communities. And of course, we will post them to social media. And last but not least, we want also to extend this benefit from guidelines, not only into Lebanon, but also to patients in the region. And because our program is a WHO collaborating program, we agreed with the WHO to support more evidence about vitamin D impact on the musculoskeletal outcomes and mortality through systematic reviews and meta-analysis conducted on evidence worldwide and applicable to the region. And therefore, we will engage with the Eastern Mediterranean Regional Office leadership to identify other WHO collaborating centers in order to see which centers are interested in adopting and, of course, if needed, adapting these guidelines. We will also work with the International Osteoporosis Foundation to identify national societies for osteoporosis in order to collaborate with them and see who is interested also in adapting and adopting these guidelines. With this, I'm done. If you have any other thoughts for dissemination, they are welcome, and thank you.
Thank you, Dr. Arabi. And now our session came to its end. It was a great pleasure to be with you all today. I'd like to call Drs. Hashlayhan, Arabi, Shura, and Ael to join me on stage for the closure.
Thank you so much. This was really a very, very quick recap of work that has spanned years. I thank you for being present with us. I want to take the opportunity to see if you have any questions. We're welcome, input, comments, and we have a few minutes for that. And if not, I will ask Dr. Adib to start.
Thank you very much. There's no need to add what has been said in terms of exalting the work that has been done. The endeavor is absolutely harrowing. But I'd like to address the question to Eli. There's a contextual event that happens when an elderly person enters an institution compared to an elderly person who is in the community. They lose weight. And the question is, how much does losing weight optimize the action of the supplementation and can explain as a confusing factor the difference between what's happening with supplementation in and out the institution? I'm sure that you must have looked into it. The interest is, of course, to retroject this information on the primary prevention. It was not included in the guidelines. Essentially, if we work on obesity and keeping our weight controlled, maybe the epidemic of hypovitaminosis may be controlled one day.
Thank you, Dr. Adib. في إسعام بالجمهور. I think the endocrinologists are better suited to answer this question.
Okay, so from a nutritional standpoint, and your point is very well taken, it's not just calcium and vitamin D. There are other nutritional factors, protein intake, et cetera, that contribute to the frailty, the sarcopenia events, et cetera. Now, if the question is calcium, vitamin D alone enough in a person who has this sentinel event of hip fracture, of course not. If the question is, does vitamin D contribute to frailty and sarcopenia? The answer is maybe. The evidence from vitamin D helping with fall prevention is controversial. We're about to launch our effort to do what we just did for fracture, for falls and sarcopenia. So I think the main point to be made from your question is it's a multidisciplinary, multi-pronged approach. Physiotherapy, nutrition, protein, calcium, vitamin D, drugs, ambulation, muscle strengthening, balance, so on and so forth. So it's not as simple as we're not claiming that calcium, vitamin D will reduce hip fractures substantially alone. We're just saying this is a niche of patients at high risk who may benefit based on the evidence available today. Is that reasonable? Of course, it has to be underscored. It's a balance of multiple other factors. Absolutely, point well taken. So there's a question by Dr. Ghassan Awar. Thank you. Other than fracture risk reduction, vitamin D is recently dealt with as a hormone with multiple and far-reaching benefits beyond the important bone strengthening effect. So what about recommending generally to the people who did not get enough sunlight in their busy daily schedules? Thank you, Dr. Awar. I think what we have presented in grand rounds, not here, and what Dr. Arabi presented this Monday in our series is that although there are many association studies suggesting a protective role of vitamin D on non-skeletal outcomes such as cardiovascular disease risk reduction, breast cancer reduction, and the list goes on, the evidence is not strong enough to recommend it based on the efficacy on these outcomes. I don't know if Marlene or Asma would like to add to that.
Just I want to add that maybe Dr. Awar meant the people who are not exposed to sun enough, maybe with concealed clothing. So in this case, yes, these are people who are at high risk, but otherwise in healthy population, there's no evidence.
There is a question by Christelle Ephraim. What about vitamin K in improving vitamin D absorption? In which cases should we prescribe it with calcium and vitamin D supplementation? Do you want to take this? Anybody wants to take this? Vitamin K with calcium and D?
So thank you for the question. As we have shown, we have set the specific questions that we were going to assess. We determined the population of interest, the intervention, and the outcomes that we intended to answer during the guidelines. So we didn't come to assess the effect of vitamin K specifically concomitantly with vitamin D. However, we do not routinely advise to give vitamin K with calcium and or vitamin D because we know there have been some heterogeneity in the evidence specifically with vitamin K.
Yes, تفضل Dr. Abed. So Dr. Abed is saying K and D are absorbed by different mechanism and they are not related. With the absorption issue, yes, what people marketing vitamin K with calcium more than D is the issue of prevention of calcifications in the blood vessels, which has not been consistently shown. So you're absolutely right on the absorption, but the co-treatment with calcium had to do with minimizing calcium deposition in blood vessels. Potentially related to bone metabolism. Yes. تفضل دكتور عذرا. Yes. Thank you so much, Dr. Adra. Yes, it took us 3 years to do this for falls and adults, and other 3 years, maybe 2 with the rodage for the next one. Thank you so much. Let me just say, very important point, a lot of huge doses being poured into our patient, which may not be safe. Just allow me to say, by the time we get to this, and hopefully we will, there is a very nice systematic review by Dr. Pina Rosa, who works with the WHO Geneva Nutrition Group. I'll be more than happy to send you that. Screening, no, WHO does not recommend screening. Potential effect on some obstetrics outcomes, maybe. Certainty of the evidence is not very good. So it's a very good point and well taken. Thank you. There is one question from Dr. Jihad Makhoul. I was wondering whether you found any vitamin D positive effect on cardiovascular system, not hip fracture with calcium, and whether that would be of interest as well to your team. So as Dr. Shahtoura said, our PICOs were very pointed to a specific outcome, which was fractures. We have not conducted a systematic review on vitamin D and cardiovascular. There are several out there with controversial results. They may be a weak signal for decreasing mortality, but I can't comment on that. Dr. Makhoul, again, could you say a few words about what type of input you obtained from research with patients? I'm going to leave the floor for my colleagues maybe to also input, and I'll be happy to add. So, survey.
So we have conducted a questionnaire, a survey in the VMD and endocrinology clinic, checking what patients would prefer in terms of supplementation, whether tablets, liquids with calcium, without calcium, whether they would go with their physician's recommendation or the pharmacist or someone else suggesting for them, for example, to take vitamin D, whether cost would be an issue, etc. So we didn't have the chance to really show all these data, but these were the items assessed. And to note that in the guidelines panel, we had a patient representative who was taking part of the voting process. So again, her feedback was taken into consideration.
Dr. Abed? Yeah. Marlene, do you want to comment on that, on the systematic reviews? Okay, so again, this is another, by the way, this is another, huge topic, right? So the teaching was classically that D3 is better than D2 because it may have better effect. But there is a confounder to that, is that not all assays that measure vitamin D pick up D2. So when we say D3 is better, it may be just that you're not picking up the D2. Having said all that, experts, not myself, have really pointed out to older literature that suggests that D3 is more biologically effective than D2. I cannot tell you that we've looked at that in the systematic review because the type of data that Dr. Chahtoura has gathered from the meta-analysis that looked at randomized trials did not always differentiate D2 from D3. Yes, maybe, but now there is D3 in most preparations. Yes. Okay, so there are no more questions. I'd like to ask the panelists, Dr. Abyad, our audience, to just get together here for a group picture to acknowledge your presence, your contributions, and any suggestions to us on the COMP email are welcome for dissemination. So please join us. تفضلوا. جوان انت من اهل البيت. We want really all of you, the students, the faculty, please come down, please. We'll have the panelists, Dr. Ghannaji, Dr. Aes, Dr. Shtay. I don't know if I'm missing anybody. دكتورة نور الدين تفضلوا. دكتورة هوري. Dr. Mahmoud Shair, please تفضلوا. ما بدكم عزيمة, please. Everybody should come down who feels like being with us. تفضلي دكتورة هلال. مايا تفضلي. يلا دكتورة إيس. علي تليفوني بجداني صورنا. بعطيك اياها Thank you. Thank you. Yes.